Thank you. 9 days ago, as you were aware, the new term started. So for those of you that need to, please do the portal, ASIN portal site to register your terms. I guess concurrent to that, if you want to arrange, I actually don't mind, I'm sure Ruth does it in terms of the early term meeting, just to touch in, see how things are going, maybe set some newish objectives if need be. And the second thing is, I'm sure you guys have been getting regular emails from regarding the United, that ED Micro website, and it's a wash with lots of QRGs. I know we get a bit overwhelmed, but sometimes if you're perhaps a bit unsure of a particular process, certainly more than I might be even up to date with than some of the other consultants, it might be a useful reference point to have a bit of a look and think, oh, how are we supposed to do things? And so it's maybe worthwhile spending a little bit of time occasionally. I know we had to when we did some of our competencies when the new ED opened, but they're constantly being updated, as I'm sure you're probably aware. That's all. Thanks, Sam.
Thanks, guys. All right, so I'm just going to present this scenario. I have very few words in my presentation, so I'm going to rely on everyone to kind of fill in the blanks. I'm going to do what I call the big sick, and big in both literal and metaphorical sense. Let's see if this works. All right, so this is a scenario I was presented with, and we kind of see this type of patient most days. Roughly, I think the brief was 150 kilos. This guy's probably a bit more, and he's come in generally unwell for a few days, and you suspect that he has some form of sepsis. Initial observations, he's got a temperature, a bit tachycardic, and a little bit borderline hypertensive, but otherwise holding his own respiratory-wise, a little bit tachypneic, a little bit confused, but his initial gas is fine. And you suspect that it's going to be a combination or either chest or urine or some sort of empiric, unknown source of sepsis. And you give him your stat dose of KEF whatever and fluids, and you see what he does. But then the next hour, he begins to deteriorate. So while his temperatures come down, his heat index don't look as good, and certainly his respiratory effort is starting to increase as well. And most alarmingly, his GSS is dropping, and the gas shows some ventilatory failure. So, really the first question, and I know this is an airway talk, but does this gentleman need intubation? And if so, when, where, and how we're going to do it? I'd just like to get an opinion from someone, and I'm just going to look at the list. Who hasn't talked? I don't know who's here. Kieran, is Kieran there?
Yeah, I'm here. Do you mind putting the obs back up again? Yeah. Sorry. The trend is definitely. Sorry, I'm just out on the street, so it's a bit noisy. It's definitely concerning with the trend. I don't know necessarily about whether to intubate him at this stage, but I think given he's someone that we would definitely predict a very difficult airway for, he's probably someone that I would tube earlier rather than later compared to others.
Yeah, and I think it's a good point. Because you think high level there, like this is a guy, when you look at him, you're thinking if he gets worse, things are going to be dire. And so is tubing early the better plan? But if you are going to tube, you essentially, once you induce this guy, there's no turning back. You know that you have to go, you're going to have to pursue this one way or the other. And is it better that we do this in ED, or is this someone who we can bridge, potentially go to ICU? But that's kind of discussion about what your resources are, what time of day it is, all those kind of things. But in terms of the actual intubation itself, there are a lot of things that we need to consider. And obviously just looking at this guy there, you're going to run into some major complications. And I think we talked about Matt's talked about all the kind of baseline problems that you would kind of encounter. But for this patient in particular, my main concerns are going to be anatomical problems with airway and getting a view. But more importantly, all the physiological issues that you are going to encounter. And that's probably where the meat is. But we'll start with the anatomy stuff. Is it Hassan? Hey, Sam, is next on my list.
Sam's a medical student.
No, okay, sure. Who do I don't know who anyone on this. We've lost a lot of people.
Katrina, are you still there?
Yeah.
Yeah, go for your work.
So try not to give any like actual answers as in mitigation things. So just purely looking at the problems that you're going to face, I guess. Yeah.
So with this guy, I suppose it's going to be facial hair, body habitus, whether he'll tolerate lying flat and positioning him, mouth opening, Mallampati score, his thyromental distance. Yeah, I can't think of anything else.
Yeah, it's all those kind of basic, airway, laryngoscopy things that you're going to encounter. The crux of it is what's really going to prevent you from getting a view is position for this guy, because when you put him in a standard lying position, even on a pillow, his kind of ear-to-sternal notch level is going to be way off given his girth, his body habitus. So what are you going to try and do to optimize the view as much as you can? Because really, actually, when you think about it, once you get this guy into a position, I rarely encounter a bad view. If that makes sense. It's never these people who, once you put the scope in, that you can't see the chords. It's always the ones you don't think, like the small Asian ladies. These actually the larger people. Once you get them into position and you get the scope in, the view itself is actually fine. It's more about getting there in the first place. But you're right, getting him into that position, lying him down flat when you're going to do that in terms of during the induction is going to be tricky. And it's something that you will have to plan for. But then the physiology, particularly for this gentleman, is going to be the big ticket item. So how about Matt Redman? I'm not sure if he's spoken. Based on all those obs, the clinical scenario, what are the kind of complications that you're going to anticipate?
Yeah, so one of the thoughts in patients who are obese is trying to pre-oxygenate with something like NIV, but in someone who's already borderline hypotensive, that's a very significant risk, particularly if they're septic. I know the patient was hypercapnic as well, but may have an element of chronic obesity, hyperventilation, or OSA as well. Yeah, so that blood pressure is going to be a significant risk. I'm not sure if he was hypoxic from those second
he
obs.
was needing more oxygen, essentially.
Yeah. So yeah, there's going to be a big risk there, and with that blood pressure, if you're trying to give positive pressure ventilation, so that'll be significant.
Yeah. I mean, these are the intubations that we love because they're meaty. And I'm just going to plug essentially MCRIT. I'm not sure if everyone's probably heard this MCRIT podcast. This is like kind of a classic one. I think it's quite a few years old now, and it's from the laryngoscope as a murder weapon series, where essentially we all like the tube, but the actual mechanics is the easy part, and it's making sure that you don't kill your patient. And the main things that are going to kill your patient are the hemodynamics, hypoxia, and acidosis. And in this gentleman, he has a combination of all of those. So you have to, and if you get anything out of this talk, it's the mantra of resuscitate before you intubate and plan for failure, plan for the worst. So it all comes back to focusing on the big parts of the planning and the preparation and trying to optimize things as much as possible. So if you focus on the patient, what can you do for him? Steph, I guess, over to Steph. So looking at just kind of all patient factors, like in terms of anatomy and the physiology, what can you do to optimize things before you go ahead with intubation?
So from a anatomical perspective, the hardest bit is going to be just his neck and then torso. So we probably need to sort of sit him up somehow using, is it called a ramp? Like those? Yeah,
so do you know what we have in ED?
No.
So we have the Oxford pillow, which is essentially a pre-made foam ramp. and has it kind of runs up like this. And then you can also get like a little head cradle insert that goes underneath the head as well. And they're specifically designed for these larger patients to try and achieve that neutral position. So getting that ready and prepared for him would be key.
Yep.
And then what else could you do?
So then from a physiological perspective, I mean, he's hypotensive and tachycardic. I think he just needs resuscitation before you can give him any drugs. So whether that's fluid initially or inotropes or vasopressors started already. So you might want to think about like Artline already and making sure he's got good access, obviously. And then, I mean, it's hard because his ventilation is failing with his CO2, and the only thing that's going to fix that is either like NIV, which, as Matt said, that's probably a bit risky, and then intubate. So I guess if you could try and improve the blood pressure and the heart rate, that might put you in a bit of a better starting point.
Yeah, I mean, that's great. I mean, and it's hard because the patient's not in front of you. But essentially, everything you've said is everything that I would also try. I think we all do this, and the kind of aim of this exercise is to make it very explicit and making sure that plan is kind of made clear to the whole rest of the team when you're in this situation. So yes, you do want to pre-oxygenate this gentleman, and NIV is probably the best thing that this guy's going to do. It's going to buy time. Is he going to tolerate the NIV? That's going to be mitigated, like dependent on his blood pressure, which we can try and fix as well, and his compliance, given that dropping GCS. So is he going to be agitated? Is he even going to tolerate the NIV? Are you going to have to give him something to try him, like do a delayed sequence intubation? So these are the things that you need to consider while you're trying to optimize. But yeah, I would definitely be giving this guy NIV, getting an outline, starting NORAD on spec up, even with the fluid resuscitation. And because that's essentially what you can do once before you take away all his catacholamic drive. Anyone else got anything to add to that? That's the biggest part, I think.
Are we able to achieve like the reverse Trendelenburg tilting in ED?
I think we can. Yeah, on the beds. Anyone?
There's famous pictures of these patients. So those ramps that Ken showed a picture of don't always cut it depending on the particular configuration of the morbid obesity, and sometimes it needs a customized physical ramp made up of an assembly of blankets. But as Anne correctly said, I've heard it said from anaesthetic crew that if you do it all right and take the time and you've got the time, then the laryngoscopy side of things ought to be okay, and it's all this other stuff that you guys are all hitting.
Yeah.
And actually, the way to get the time to do the prep is to start thinking about it very early on, before you start to crash and burn.
So just moving on, I mean, equipment, I'll just quickly, but the equipment stuff is fairly standard. In this patient, if you're going to intubate difficult airway, making sure you have all your difficult airway equipment that Matt's kind of already gone through. Drugs, again, dose reduction, making sure you're treating something that is more hemodynamically stable for the gentleman. So it's ketamine, which obviously is my go-to, and I always go rock. But there's no reason why you can't do sucks, but rock rocks, obviously. But also what else are you going to give? So inotropes and all those things. Team is your other big one, because this is going to be a high risk intubation. And like I said, all those factors about what time of day it is and who you've got in terms of resources, your team is going to be particular. This is even overnight, even during the daytime, is this someone that I would call anesthetics down for? Probably, absolutely. This because my expertise in this scenario is mainly going to be around the resuscitation and team leading. The intubation itself, we can leave to the airway specialists, and that's fine, unless I have some other team members who are keen to do it. But all of the trouble is going to be around the preparation and the resuscitation. which is where we're going to shine. And then making sure that you have the plan, and we're going through the vortex model in terms of what your plan is for failure and when you're going to pull out and move on. It's not really much more than that. This is all about buying time and making sure that you optimize your patient as much as you can, because the airway is not the critical thing here. The critical thing is he is sick, and yes, he will need intubation, but you need to make sure you don't just jump in. So this is something I found, which is great. I love the mnemonic. RSI, morbid obese and maybe sick patients, big ramp, and B is your buy time. Optimize as much as you can, and the rest is all fairly straightforward. That's it.
So to pick up on An's point about potential involving anesthetic, this is actually the one patient that may very well benefit from an awake fiber optic, because you could keep him upright, which will assist his own ventilation. Because An is completely correct. The airway is not the most crucial thing, although we have to get there at some point. It's all the stuff that goes before. And actually, after you get the airway, the ventilation becomes a massive issue. Because
I didn't even talk about that.
Yeah,
I mean, not that talk.
That was not good, but you need to think about it. You can't just get the airway thing and think, oh, great. Because when you take over breathing for him, you are never going to be able to do it really well. So this is the patient that needs to go this is the one that I want to teleport to ICU so that they can go straight on the ICU ventilator. And so those are all reasons to get ICU and anesthetics involved early. Cool. Thanks, An. All right, one more.
Just really quickly,
Yeah.
it says put on that mnemonic paralysis only if needed.
Which is the point about the awake fiber optic.
Yeah, okay.
I mean, if you were going to intubate him the usual way, you definitely have to paralyze him. Anne and I will disagree about which paralytic agent, but the fact is that at some point paralysis is required to get past the cords, unless you're doing the awake fiber optic.
Yeah, okay.